So our next speakers today will discuss what's working in stroke rehabilitation, bridging the gap between research and real life. So Brittany Colbank is director of the Johns Hopkins Occupational Therapy Acquired Brain Injury Fellowship. She is an AOTA board certified specialist in physical rehabilitation and earned her master's degree in occupational therapy from the University of Pittsburgh School of Health and Rehabilitation Science. She's also a certified brain injury specialist trainer. Pei-Ting Lian is a clinical resource analyst at the Johns Hopkins Outpatient Rehabilitation Network, where she oversees the outpatient neuroservices programs. She also serves as the neurorehabilitation program manager for the Sheikh Khalifa Stroke Institute. She holds a doctorate in physical and that cut off a word, physical therapy, and is a board certified neurologic clinical specialist. So thank you both and welcome.
Thank you. You guys can hear me okay? So good afternoon. Thank you so much for joining us this afternoon. We're going to shift a little bit and talk about what is working in stroke rehab. It's really hard to follow Maddie and Lee, I'm sure, so I'm going to give it a best shot. Here we go. So we want to thank our sponsors, and we don't have anything to disclose. So the content we will be sharing may be a little bit harder to digest, but we do hope that you are able to find value in what is most relevant to you. So by the end of the session, we aim to outline current evidence-based best practices for stroke rehabilitation across the continuum of care, discuss the feasibility and potential barriers to implementing evidence-informed practices, as well as sharing practical strategies and advocacy approaches to promote best practices, regardless of your role in the stroke recovery journey. So the Global Stroke Bill of Rights was established by the World Stroke Organization, and it states, as a person who has had a stroke, you have a right to the best stroke care, be informed and prepared, and be supported in your recovery. As a stroke survivor, you have the right to recover and be supported in your recovery journey. You should be provided with hope for the best possible recovery now and into the future. You should receive not only physical, but psychological and emotional support that best meet your needs, as well as being supported to return to work or other activities that are meaningful to you. You should have a way to be connected to other stroke survivors and caregivers, as well as being included in all aspects of society, regardless of your disability. So based off of this Global Bill of Rights, how are we currently meeting these rights as a health system? So to answer that question, we first need to dive into what is the current best practice for stroke rehabilitation guideline. So in this 2016 American Heart Association Stroke Rehab Guideline, some core principles have been highlighted, and such principles include early and intensive rehabilitation to improve outcomes. Coordinated and multidisciplinary team is needed. Patient-centered goals and family involvement are essential to the success of a stroke survivor. Developing stroke rehabilitation guidelines require acknowledging the complex and multi-dimensional nature of post-stroke disability and recovery, which affects medical, physical, cognitive, emotional, social, and economic domains. So for this reason, it is noteworthy that the present guideline emphasize the efforts of a sustained and coordinated effort from a team, including the patient and his or her goals, family, friends, and other caregivers. The effectiveness of rehabilitation program therefore also relies heavily upon coordination and communication across team members. So this 2016 guideline also strongly supports helping stroke survivors stay active at home and in their communities. And there's good evidence that these approaches do work. But when it comes to getting people back to work, the research is limited. So returning to work after a stroke is still an important but overlooked part of recovery. So now we move to this update that replaces the 2019 Veterans Affairs and DoD guideline on stroke rehab. And this practice guideline is really designed to help primary care providers in the VA and the DoD to manage stroke rehabilitation for adults that are 18 or older, and emphasizes an interdisciplinary approach. It also offers evidence-based recommendations for stroke rehabilitation specialists. It highlights the key areas of strongest evidence, which included community transition, which includes case management at discharge, psychosocial or behavioral interventions for patients and caregivers, motor therapy, specifically task-specific practice, domains of swallowing, speech, and cognition, as well as mental health recommendations. And then as we move overseas to the United Kingdom, the National Institute for Health and Care Excellence focuses on all healthcare settings in the UK, including community. There is a strong emphasis on early, intensive, and multidisciplinary rehabilitation. The new updated recommendations included use of tele-rehabilitation technology, return to work programs, and community engagement, as well as early supported discharge and structured transfer from hospital to the community. So creating these guidelines is no small feat. Unfortunately, most guidelines do not explain how to make their recommendations happen in real life. That means clinicians and researchers need to take the lead in sharing and applying these practices. So I don't know if you've ever heard of the 17-year gap. It's a time frame required to adopt new practices that are derived from clinical research findings. Unfortunately, new research shows that it may take even longer to de-adopt unnecessary practices. So luckily, in recent years, more emphasis has been placed in efforts to employ implementation science research to expedite the process through examining barriers to implementation, facilitators of implementation, as well as implementation strategies. So more commonly, it's described as knowledge translation, which is the process of adopting evidence-based knowledge and integrating it into clinical practice. So at Johns Hopkins Shea Stroke Institute, we had the opportunity to reevaluate and redefine established standards for stroke care. So we can see that the focus historically has been on triage of patients and how to move them through the continuum of care instead of recovery, because the length of stay usually dictates how long a patient stays within each setting. And oftentimes, patients are transitioned to the next level of care before they are really ready, which could be to the home or to a facility. But as a result, patient coming out to the outpatient can be still significantly impaired. So in order to shift from the current care, focusing mainly just moving patients along the continuum instead of trying to focus on recovery, we needed a new model of care for recovery and rehabilitation. So each circle here highlights the crucial components of this new model. So it includes the integration of care across levels. We build an outcome database. We develop algorithms for precision rehabilitation, disseminate through a learning network, as well as demonstration of effectiveness of the model. So now we're bringing it back to the basics. Neurorehabilitation process is really grounded in the principles of neuroplasticity, where we often hear the terms of use it or lose it, use it to improve it, as well as repetition matters, intensity matters, which is all supported by current literature. But do we know when is the optimal time for intensive motor rehabilitation? So from this study by Drumrick in 2021, it showed that there is a critical period for intensive motor rehabilitation in human beings, which is at the 60 to 90 days mark after stroke. They show that intensive therapy during this window results in better outcomes. So how did they find that out? Well, they had 72 participants with recent stroke that were randomized to receive 20 extra hours of task-specific upper extremity motor therapy at one of 3 time points. So it could be at an acute time point, which is less than 30 days after a stroke, subacute, which is at the 2 to 3 month mark post-stroke, and then chronic is 6 months post-stroke. So your control is basically the standard rehab only. So in other words, about this research is if you need to give 20 additional hours of therapy, when should we give it? And when is that critical period? So it also showed that early high frequency rehab, which is about 18 sessions given over 6 weeks in the first month of post-stroke, really can mitigate disability. This is the result of the study where in the early phase, they receive therapy. And then in the subacute phase, which is really right after they are discharged from inpatient, and patients still had improvement in their upper extremity function after 1 year of stroke. So what if we missed the opportunity for early high frequency rehab? It is encouraging to see here that from this graph, there really is no plateau in recovery, but it will take longer, up to 100 to 300 hours, which adds to healthcare cost. So now that you know what research is recommending, how do we implement it into practice is our biggest challenge. First, we have to identify what are the existing challenges and gaps to achieve our proposed new model of care. And these challenges can be categorized into operational challenges, challenges in establishing consistent outcome assessments, and as should be across all settings from acute care all the way out to community, and challenges to establishing treatment approach consistency. So ultimately, the implementation process needed to be fluid and adaptable as this process continues to evolve. So some operational challenges included siloed care. People didn't talk to each other as providers. Patients lost in transitions. Dosing and timing of neurorehabilitation, as well as staffing. So outcome assessment challenges included different outcomes collected within each setting, the timing of when we do these outcomes, and the documentation of the outcomes. Education and treatment approach challenges included the communication and consistency of care amongst therapist team and care team.
And we know that early activity and mobility programs can reduce length of stay, decrease readmissions, and improve functional outcomes after stroke. Through our AMP program, as soon as patients are deemed medically stable, their mobility is initiated by the nursing team. I'll speak more about our intensive acute rehabilitation program on the next slide. And so as many of you, or if not all of you know, if a patient requires additional rehab before they're able to safely return home, they may need to transition to an inpatient rehabilitation facility or potentially a subacute or skilled nursing facility. Once the person is home, some patients benefit from home health and may also require outpatient therapies to address residual impacts of the stroke that are holding them back from their optimal level of participation. So although home health and subacute rehabilitation or skilled nursing facility are not listed on this slide because it is not considered part of our high intensity or high frequency pathway, I do want to make note that we do offer all levels of care through the Johns Hopkins Rehabilitation Network. And so while we do not lean to a one-size-fits-all approach to rehabilitation, we do lean heavily on those principles of neuroplasticity. And in order to ensure that we're providing the optimal dosage and intensity that Pei-Ting was alluding to for every patient, we really strive to integrate care and teamwork across this continuum. So this means that we place great value and effort into synergizing our operations, our outcome measurements, the technology implementation and education and training across all of these levels of care, because different patients will spend different amounts of time at each level. So in other words, we're striving to meet every person where they are and provide access to the resources we have available within our system, regardless of where they may be sitting. Next slide, please. Oh, I'm sorry. No, not next slide. Or no, we're good. All right. The ARISE program is our enhanced level of acute rehabilitation. In this program, patients can receive up to 2 sessions of each therapy discipline for a daily total of 6 sessions per day. Therapy evaluations and consultations are ordered by our neurology team based on the person's impairments. One session of therapy is planned to be focused on identified impairments, while the other one is focused on function. This ensures that the patient is receiving a skilled intervention that addresses both aspects of recovery in parallel. And it is contrary to the usual acute care therapy where focus may be on function and compensatory strategies to facilitate that discharge to the next level of care. So in addition to the therapies, physiatrists or rehab doctors are involved early in the patient's care, so they get consultations ordered at the acute level are on admission, and then the rehab team is collaborating with nursing, neurologists, and case managers from the get-go to form an individualized treatment plan for each individual patient. To touch on implementation or what this looks like in a day-to-day, each patient that has had a stroke and is within this pathway or is provided with a daily schedule that's posted at the nurse's station. And every session that's scheduled for them from the therapy disciplines will be at least 30 minutes. So that would total up to that 6 total sessions per day. And then there's a daily huddle that occurs mid-morning after at least one therapy session has been conducted, which includes the therapists, PT, OT, and speech language pathologists, as well as the physician, where they discuss the patient's progress to date, any barriers to progress, what the recommended next step is going to be in terms of discharge location, or any adjustments to frequency that may be needed based on activity tolerance after about 2 weeks of participation in the program. So the team recommendation is then shared with the additional team members, like neurology, case managers, and nursing through our electronic medical record communication system. If you are interested in seeing more details about the PT, OT, and speech language pathology evaluations and interventions, this article thoroughly outlines impairment and function-focused interventions that are spearheaded by each respective discipline. So again, talking about the physiatrists who work with the patients, they are sort of like the quarterback of the team. They collaborate between the acute medical team, the therapists, and the families to discuss person-specific stroke education, talk about rehab goals, and calibrate expectations between the medical rehab team and the patient and their family. Nursing collaboration is very critical for this to run seamlessly. So before starting any session, the therapists are reviewing the patient's chart and discussing medical stability prior to entering the room with that primary nurse. After the session concludes, the therapists are going to communicate any change in status, update in progress, or position in which the patient was left, as well as any new recommendations as it pertains to helping to safely handle that patient, provide positioning, or any utilization of new devices. And then outside of direct patient interaction, there's further coordination care with nursing during daily multidisciplinary rounds and monthly operational meetings. Next slide.
Okay, so once a patient is ready to transition out of the hospital, rehabilitation becomes highly variable. Hence, we saw the need to bridge the care with care navigation. As Brittany has shared with you how the inpatient team has adopted that ARISE program to optimize care, the patient facing challenges upon discharge becomes the next challenging thing for us in outpatient. These barriers are specific to our institution, but seems to be generalizable to many different settings around the world. The 4 common barriers include limited caregiver support, transportation issues to get to outpatient or community care, financial constraints impacting the number of visits approved, and resource constraints of the health system. So for example, historically, there is no outpatient case management or social work assistance, which is a lot of these challenges lands on the outpatient therapists as well as patients and families. There also was not a point person to assist a patient in navigating the health system from inpatient to outpatient. So, to address the four common barriers, we came up with some patient-driven solutions for each. So, under resource constraints, to mitigate the challenge of patients getting to outpatient services, we were able to advocate for a stroke navigator position. That is a full-time position to assist stroke survivors in navigating their recovery journey across the continuum of care. As I mentioned, historically, outpatient did not have social work support. So after a lot of advocacy and persistence, we were able to get the Johns Hopkins Department of Care Coordination and Social Work Services to provide us with a designated social worker to assist our outpatient team. And so, under limited caregiver support as a challenge, we collaborated with the neurology team, and there's a program called a J-STEP program, which is a telehealth visit with patients and caregivers within the first week of their discharge from acute care. This allows the healthcare team to check in on how things are going with transition to home. And another solution was early education to family and caregiver from both inpatient and outpatient team to assist with transition planning. Now, under transportation, when a patient is an inpatient, they're essentially captive audience to receive therapy. When discharged home and they are not able to drive due to their recent stroke, then getting to therapy becomes a burden and a challenge. We were able to receive funding to use Lyft to get our patients to outpatient services, but initially it only included those that had the mobility and cognitive capacity to use the app to get in and out of Lyft and navigate the hospital. But after we got our stroke navigator, he was able to come up with a solution of an augmented Lyft program to further support those that may need assistance in using the app or navigating the hospital or getting in and out of their Lyft rides. So the team also actively assists with mobility applications and integrating community transportation access as part of their treatment plans. And lastly, under financial constraints or limited insurance coverage, our transdisciplinary treatment planning, customized home exercise program and activity plan, multimodal learning with our patients and caregivers were our efforts to try to provide meaningful and salient therapy within the financial constraints. So now I'm going to hand it over to Brittany.
Thank you. And this is a great segue into this recent and insightful publication by Fu and colleagues who are international clinicians and researchers. Their messaging aligns with our goal to prioritize function and emphasizes the importance of looking beyond someone's impairments, rather highlighting the importance of a whole person approach to stroke rehabilitation. We know that psychosocial well-being is a major component of health, but can often be overlooked in traditional models of care because there's so much to accomplish in such a short amount of time. And sometimes it feels like teams are doing all that they can, even if they feel like they're not doing enough. But there sometimes feels like there's not enough time in a day or not enough days in the length of stay. So this article reviews recent research and introduces novel considerations to optimize long-term outcomes for each individual. So think about it this way. If traditional therapy aims to address stroke-related physical, communication, or cognitive deficits that restrict an individual from living their fullest, what happens when someone hasn't reached their full independence or returned to their baseline from before their stroke occurred? How have they emotionally adjusted to the challenges that they've faced? Perhaps they have a profound financial strain and a lot of stress associated with this because they haven't been able to return to their original work. As Pei Ting mentioned, return to work is a gold standard type of outcome, yet it's really hard to figure out how we make this happen for the majority and make it systematic and equitable. Or think about how a musician who has graduated from outpatient occupational therapy feels when he's graduated from and passed all the dexterity tests, but can't achieve the same rhythm and timing that used to come so naturally and automatically. How does that impact that person's sense of self? Not to mention, as humans, we are social beings who need to feel connections to others. but stroke survivors often face some degree of social isolation, which could be prevented with the right type of proactive support. Next slide, please. Psychological impacts, which could include mood, coping, and self-efficacy, have been associated with poorer outcomes as it pertains to life participation and levels of disability post-stroke. So for any provider who is looking to push the boundaries of traditional care or add a little bit of extra to the service that they provide, the first step is to think about the big picture for the patients we serve and to provide guidance to help them feel empowered to take control over their own rehabilitation journey. When we think about psychosocial well-being, it's not just about the absence of negative psychological factors or negative thoughts but also the presence of positive factors that do contribute to that longer-term well-being and resilience. These emerging but non-conventional concepts that are outlined on the slide have been shown to effectively support individuals in increasing their engagement in meaningful life activities, and engagement is what life's all about. That's why we all went into the field of rehabilitation, because we want to help people engage in what's important to them. Now, I would like to take a few moments to elaborate on some of the key areas of focus that I gleaned from this publication. So some of the language may not be familiar to everyone. So self-management programs are designed to help individuals cope and manage with various conditions while building skills and self-efficacy to resume a productive and dynamic life. These types of services have been proven to improve quality of life and reduce disability for several populations. Peer befriending or peer support involves connection of two or more individuals who have a similar condition and have been proven to be beneficial across multiple populations, including for individuals with stroke, highlighting aphasia in one article that was referenced. So this type of supportive relationship can provide mutual encouragement, create connections and friendships, and address unmet needs that simply can't exactly be addressed by healthcare providers or even family members or friends that haven't experienced a stroke themselves. To touch on family, friends, and support persons of individuals who are recovering from a stroke, it is the standard of care to involve caregivers in goal setting and education at the start of the recovery process, but more evidence is emerging as it relates to the value of addressing the wellness needs of the caregivers themselves, as the natural role shift that can occur when one transitions from being, let's say, a partner, a parent, a child, to a dual role of being one of those things and a caregiver, that can impact someone's own health as well. So in turn, that would eventually have an impact on the care that they're able to offer to their loved one. And then it's very important to consider who has the resources and the support to live well after stroke, or who may be facing adversities as a result of social determinants. Post-stroke outcomes are consistently found to be worse for marginalized populations. As a collective group of clinicians who practice in the field of neurorehabilitation, I know we strive to practice cultural humility and the willingness to learn from individual patients and the families we serve, but the research proves that disparities still exist, and more collaborative research and funding is necessary in order to ensure that the services that we can offer are truly equitable. So in summary, while still leaning heavily on the biomedical approach, which emphasizes potential for creating neuroplastic change in the brain after stroke through we lean heavily to promoting neuroplasticity for impairment-driven interventions. If we continue to focus as well on this biopsychosocial aspect, we'll continue to strive to prioritize outcomes that are meaningful for individuals beyond their impairments and advocate for policy and system changes, because we can prove the value of additional personalized outcomes that touch on things such as quality of life or participation. In the immediate future, as clinicians, we can keep in mind the value of promoting self-management skill building for our patients, ensure that we are offering family-centered care that is culturally informed, facilitate peer support as we're able, and not to mention considering remote or telehealth services as feasible to ensure that we're providing increased accessibility for those that may not be able to come in person to see providers. Next slide, please. So again, the rehab process aims to maximize function. We've said the word function a lot in this talk so far. However, there is significant variability in how people respond to different interventions, how they recover, and a lot of it depends on those factors that we just reviewed. With a highly heterogeneous and individualized pattern of recovery, it can be challenging to systematically determine who will benefit from recommended interventions at what time. So in traditional rehabilitation, stroke rehabilitation, a patient from the population comes, gets evaluated by the team, and we have a strong clinical understanding of what pathway they're going to be placed in, and they receive a certain set of interventions that are pretty consistent because we have clinical practice guidelines, but they're still kind of grouped into broader groups and maybe dependent upon the care that they receive or the timing of their care. Precision rehabilitation is an emerging field in healthcare that seeks to deliver highly individualized rehab plans. It draws inspiration from precision medicine, which customizes treatments based on a person's genetics, lifestyle, environment, and other data. It aims to deliver the right intervention at the right time, in the right setting, for the right person, ultimately bolstering the value of the care we provide and cutting out becoming more efficient and cutting out waste, if you will, for unnecessary services that aren't delivered precisely. However, the difference between precision medicine and precision rehabilitation is that rehabilitation delivers targeted interventions and uses outcomes that do focus on the day-to-day function of the individuals we serve. So this takes heavily into consideration activity limitations and participation restrictions or abilities. The goal of precision rehabilitation is to optimize recovery by considering multiple dimensions of a patient's health and abilities, which includes physical, cognitive, and psychosocial factors, while also accounting for meaningful differences across subgroups within the population. So this too stands in contrast to that one-size-fits-all approach. Think of it this way. Precision is referencing the right intervention in the right setting at the right time. Prediction means this. We have anticipated outcomes that should be expected for individuals based on their unique presentation, based on a combination of health data from biomarkers, so from their biological factors and what medical testing shows us, as well as individual technology-based data, such as activity monitors, whether it be step trackers, heart rate monitors, etc., or health profiles, sleep trackers, and things like that, as well as data from comprehensive databases that represent various subgroups within the broader population of stroke survivors. And then, of course, prescription refers to time, duration, and dosage of a given intervention. So I know that was a lot. I'll provide a case example in this scenario where no barriers to resources exist. So Edward is an expert guitar player who is experiencing left hand weakness after having a stroke. He received testing through MRI, electromyography, and motion tracking, which identified that he has partial preservation in the corticospinal tract and impaired finger isolation and delayed muscle activation in the left upper extremity. This information is informative to the occupational therapist who performs their evaluation and sets the therapy plan of care. Therapy focuses on individual fingers through the use of individual fingers together through functional task practice, with additional emphasis on activation timing. Intervention also includes the use of motivating technology such as a music glove, virtual reality systems, and motion detection, and other rhythm-based tools that give biofeedback to the patient and the clinician of how their performance is going. It's kind of like playing a video game and you get to level up or you get feedback on your performance. It can be very, very motivating when there's a focus on the task rather than what the body is doing. So Edward's prescribed an intense and specific home exercise plan, and he's provided with a smart glove that tracks his movement quality, rather than only emphasizing the number of repetitions that he completes in a given day. And again, this device provides feedback to the patient and the clinician to inform if adjustments need to be made to the home program. And then recovery is further supported by the use of non-invasive brain stimulation or transcranial direct current stimulation, which is administered by a technician during occupational therapy sessions. Performance capacity of Edward's hand is monitored with technology-based data and therapy assessments, but the ultimate goal is that Edward is going to get back up on stage and perform as a guitar player. That's what we're really striving for. So while the foundation for this process of precision rehabilitation has been set in motion, and we do have a team at Hopkins that focuses on driving this initiative forward, in order to fully bring this vision to reality in real life in a way that's accessible to all, a collective and deliberate effort needs to be made from researchers, professional organizations, and funding agencies. Next slide, please. Remember that global Bill of Rights that Pei Ting talked about in the beginning? Every person who has had a stroke has the right to receive the best care and be informed and prepared and supported throughout their rehab process. Each of us should feel empowered to be advocates for our own health because no one understands our experience more than ourselves. As a survivor of stroke, you have a voice and you deserve to be heard and understood. But it can feel daunting when you are chartering unfamiliar territory after a life-altering event. Being an advocate for yourself or a loved one doesn't need to feel intimidating. More so, try to view your healthcare providers as your partners in your recovery and rehab experience. Feel comfortable speaking up about what you think your needs are and remain open to hearing the expert opinions of your providers. When you make decisions in collaboration with your healthcare team, you are more likely to follow those recommendations because they align with your values and contextual factors that impact your daily routine. This aligns with what we've already highlighted, that a one-size-fits-all approach is not effective in stroke rehabilitation, and we need you to hold us as providers accountable to make sure that you're receiving their care that meets your needs. So to remain proactive rather than reactive in your rehab experience, you can do the following. Prepare for your appointments in advance. Make sure you understand your prescriptions and medication schedule or your home activity plan. If you're recommended a certain intervention and you don't fully understand it, make sure you ask clarifying questions. Make sure that before agreeing fully to a recommendation, it's going to be feasible for you. And if you don't think it's going to be, let the provider know so that you can talk through it together. This is especially essential for your therapy-based programs. It will do nothing for you if a therapist gives you exercises to do and then you have trouble sticking to it in your own routine and the program just stays in the folder that they gave you. So be honest with your providers and ask them to collaborate with you to find what's going to stick for you. Keep in mind that hope builds motivation, which leads to engagement. When you have a plan you feel good about, you're most likely to be successful. And then momentum is going to build more momentum. With the right plan, you'll feel a sense of control over your recovery process. Notice I said process rather than progress because sometimes things don't go according to plan. But there's always the potential to reset your plans as conditions or goals are going to evolve over time. Create attainable goals for yourself and make sure that your support system and your team are aware of those goals so that they can help support you as needed. Also keep in mind that many of us learn in different ways. Writing things down is a helpful way to get new information to stick. If you have trouble writing legibly or quick enough, then you could always ask someone else to jot down information for you that you can review later. Or ask providers if they feel comfortable if you record parts of your visit from your phone or any device so that you can review overwhelming information later. Earlier, I mentioned the importance of human connection, which is necessary for maintaining well-being and resilience. This can go both ways, whether we are the ones who need extra support or we can help to support others. When we say grow your tribe, we want you to think of anyone and everyone that could be available to help support you in your recovery. Whether it's someone that can assist you with your daily self-care, someone you can lean to as a listening ear, someone you can just have fun with, or someone that can help you stay organized. Make a list of all the people that you can think of, because I'm sure that many people that you might not tend to automatically reach out to would be happy to support you in whatever way they can. If you're a person that hates to ask for help, we encourage you to really look deeply inward and try to change your outlook on that. There are many resources available for navigating life after stroke. We wanted to highlight the Brain Injury Association of America and the American Stroke Association, which are both very reputable organizations that have resource pages as a jumping off point. And both organizations also offer pages that are dedicated for caregivers as well. And finally, I wanted to share with you some books that come highly recommended. If you have difficulty reading, or maybe it makes you tired, or you can't pay attention for long enough to get through a few chapters, maybe consider listening to audiobooks instead. The first and foremost is my personal favorite, Stronger After Stroke. If you're looking for a guide that can serve as a roadmap for your recovery, such as what therapies are available, how to navigate the rehabilitation system, or for additional motivating tips, this book is a great comprehensive guide. I've recommended this to many of my patients, and I revisit it myself from time to time. My Stroke of Insight is written by a Harvard-trained neuroanatomist who sustained a stroke and shares insight about how it totally changed the way her mind worked and processed information. It offers a glimpse into the experience of the stroke survivor, which can feel validating, but also helpful for family and friends who have not experienced a stroke themselves. And then finally, a classic that has received rave reviews is The Brain That Changes Itself, which highlights the concepts of neuroplasticity through inspiring stories and case examples. A consistent theme in this book relates to the mind and body connection. Next slide. So in closing, we do hope that this presentation offered something for everyone in attendance. We have a fair amount of time to address any questions that may have come through, or if there's any thoughts that you wanted to address outside of this forum, you can contact us through the information on this next slide. Next slide, please. And last but not least, we wanted to thank our teammates at Johns Hopkins, as we are very grateful to represent such an amazing group of clinicians, scientists, and researchers. And we thank the Brain Injury Association of America for their work and for inviting us to present today.
Thank you so
Previous
much.
slide, please.
Oh, sorry about that. Thought we were going to go. Are you, if we have a few minutes for questions, but Brittany, I'm sorry, I want to let you finish first.
Oh, no, we're good.
Okay, so we do have a few questions in the chat already, and if anybody else has questions, we do have about 10 minutes for them, so feel free to type them in. So someone said that they're an OT at an inpatient rehabilitation facility, so can you please expand on the resources for LIFT and the augmented LIFT program?
Yes, I finally hit unmute. Thank you for asking that question. So as part of the Sheikh Khalifa Stroke Institute, we were fortunate enough to get, it was funded through a philanthropic uh, gesture through the government of UAE. And so this fund basically allocated to allow us to provide service through Lyft, and that's how we were able to do that. And we are constantly still having to seek out other ways. So we collaborate with our development department so that we can find other potential donors because rides are not cheap. And that was the way we came about for the first round of funding. And then like I said, rides are not cheap. So then we had to actually build some um, sort of criteria because of the distance someone might live. So we had to somehow focus on our radius. So that definitely added into another exclusion criteria in order to keep the funding going for a little bit longer. But that's definitely, and then augmented lift basically is, so when we didn't include those that couldn't cognitively use the app or had mobility issues, we really didn't have that many people. Even though the service was there, but truly we did not get those that truly needed the service. So when Steve, our wonderful stroke navigator, came on board, he thought of this idea. And so that now widened the pool for those that were eligible for it. So I hope that answered the question.
Yeah. And says, could you please so someone else asked, could you please give a resource on the smart glove Edward used in his OT session home program?
So this is a theoretical smart glove. There are a few companies that have designed something like this, which is it typically has some level of either a robotic or an electrical component to stimulate or to not to stimulate, to monitor the motion of the hand. And then it links to a database that tracks their performance. So we've had a few vendors reach out to us that have kind of shared their products that aren't commonly used right now. So that was more what I was alluding to. But if you just kind of look up rehabilitation smart glove, you can get information on different companies. But I would not have one that I would endorse right now.
Someone else asked, as a clinician, do you have any recommendations on how to advocate for Medicare payments for acute rehab for the most critical point of treatment needs since it's now limited within for acute rehab?
That's a tough one.
I can't confidently answer that question. What I can say is, unfortunately, where we are right now, we are doing what we can with what we have. And so that's why we think about what those practice guidelines are and how we can adjust our operational workflow to do the best we can for what will be reimbursed. What were you going to say, Pei-Ting?
I was going to share that so as part of this funding really was to try to demonstrate what should be the stroke standard. And
Yeah.
as you're already expressing, like all of these challenges that we face, like basically we're trying to push people out, right, before they're ready. And so based off of part of the other component of this is to gather enough of the outcome data to then analyze it and then hopefully then publish to say, hey, these are why we are doing what we're doing and you can't boot them out and you need to pay for it for longer than 20 days if they really need it. And so at this point, I believe a lot of the advocacy that's currently going on is happening through a lot of appeals through the attendings, the physicians themselves. And it's very much case by case. At least that's how, well, what I'm familiar with as far as our acute care rehab is concerned. But I think that the hopeful part is as we're gathering a lot of this information that we could then hopefully go to CMS and present something to advocate more for the reasons for what we do.
And I encourage every clinician on here to think about the things that we discussed today and advocate within your documentation. Be confident in what you're observing, what you know this patient needs. And the more we all advocate through our documentation, then we would have more of a leg to stand on to show what the needs are.
Thank you. So you're the navigator that you referenced earlier. Someone asked, is your navigator part of your case management team? Basically, kind of where does that role sit for resourcing?
So the navigator is not necessarily, he's not part of the department for case manager and social work. So he's part of our PM&R department. And we funded that position initially was through the Sheikh Khalifa Stroke Institute. But then once the funding ran out, the department saw the critical benefits of having such navigator full-time, that we funded him for that position. And he works closely with the case management team through across the continuum. So that's also why it was critical to have a designated person to be that point person to assist.
And we have a thank you from the survivors. So it's unbelievable that you thought of the navigator for those of us who don't have family to help. Thank you. Just sharing that.
Thank you.
Um, so someone asked, I think we might have time for, I think we can do one or two more questions. Someone asked, is the arise in replacement of inpatient rehab, or is it the before inpatient rehab?
It's before. So we're emphasizing that early intervention, early high intensity intervention before they would transition to inpatient rehab, because not everyone is going to qualify for inpatient.
And kind of a connected question, someone says, do all your patients move into the RISE program?
Yes, they do. That is part of our care. And it is lasting 2 weeks. And then after that initial 2 weeks, if they're still on the care services, then due to staffing and all the other logistical things to consider, they're bumping it down to one. Currently, I'm here in the UAE and I got to chat a lot with my inpatient colleague, and she shared with me that they're really going to start looking at back to the whole point. So this is an ongoing process in terms of for those that basically had a sort of subdural hematoma, those patients basically may not benefit from the high frequency right off the bat, but they start emerging and they do better later on. So as we get more into that more timing and precision, then we may want to consider like doing more of that frequency a little bit later on so they benefit more versus doing it so early on in the first 2 weeks and then they move on to one if they're still an inpatient. So it's an ongoing evolving process. We're constantly trying to make it better, but with research to support that.
Okay, I think this is the last question we can take with the timing. Someone asked, can you speak from an OT perspective of how you incorporate high intensity training at Johns Hopkins from an intervention perspective? They're just looking for ideas.
Yeah, I worry there's not enough time for me to elaborate on this, but I will say, sometimes people mix up high frequency and high intensity. So there's high intensity, which involves getting the heart rate up and really making sure that the cardiovascular system is working to promote, to support neuroplastic change. And then there's high frequency as well. So both can be highly motivating for individuals and are very important. I really, really encourage this person to reach out to me. I would love to connect and talk in more details about my perspective on this and what we do with our team.
Great. And just thank you both so much for being here today and for your presentation. We're going to go ahead and just take a short 5-minute break, and we're inviting, our next speakers to, they'll get their slides set up, and our next session will be on ambiguous loss and stroke. So we look forward to seeing you all again in about 5 minutes. Thank you.
Thank you so much.
Thank you.